Hey everyone, welcome back to the NPTE podcast. This is Will Crane, your host. Thank you so much for joining me as we go through the content you need in order to dominate on test day. If no one has said thank you to you today, let me be the first to do so. Thank you for what you do. Thank you for all the effort you're putting into this. I know that it will not only bless your life, but the lives of your patients for years to come. I know that it's a lot of effort, a lot of energy, a lot of work to go through this whole process, and thank you. Thank you for what you do. I know that as you enter this field, that you do so not only because you're looking for a great career track, but also because you care for your patients. So very much appreciated there. Today we've got a practice question related to the system interactions on test day. So you can expect on test day to have somewhere between 8 and 10 questions related to system interactions. But before I get to that, just a quick reminder, if you're looking for a quick way to review right before test day, you'll love our crash courses. We do a 3-week crash course before every test day. We meet twice a week talking about practice questions, helping you to not only dissect the question, but understand how to logically go through each question on test day. It's a great way to prep as you go right into your test experience. Be sure to check that out. You can find all the details over at ptfinalexam.com. And if you want our sweet discounts, or if you want to be a part of our cohort deals, you can find out more information there at ptfinalexam.com/podcast, where you can get all of our tips, tricks, and be up to speed on all of our latest offerings at ptfinalexam.com. All right, so today's practice question related to system interactions, we'll go ahead and dive into that. I'll give you a moment to respond to the question, and then we'll talk about the answer together. During an inpatient physical therapy treatment session with a patient in the intensive care unit, the patient's chest tube becomes dislodged when rising to a sitting position. Which of the following actions is most appropriate for the clinician to perform first? During an inpatient physical therapy treatment session with a patient in the intensive care unit, the patient's chest tube becomes dislodged when rising to a sitting position. Which of the following actions is most appropriate for the clinician to perform first? Number 1, activate the emergency medical response system. 2, apply pressure to the insertion site and add additional lengths of tubing. Number 3, place a gloved hand over the insertion site. And 4, return the patient to supine. So we've got 1, activate the emergency medical response system. 2, apply pressure to the insertion site and add additional lengths of tubing. 3, place a gloved hand over the insertion site. And 4, return the patient to supine. All right, so this question asking about protocol when it comes to chest tubes. Now, chest tubes, they're typically used to drain any type of excess edema or fluid that builds up in the pleural space or the pericardial space, depending on precisely where the chest tube is placed. But typically it's in the pleural space. You're trying to offload any excess fluid that accumulates there, especially after some type of open chest or open heart surgery. Anything where you've disrupted the chest wall, these chest tubes are placed in order to gather that excess fluid and edema. Now, they typically have a reservoir site that's placed at a lower level, so it's a gravity-fed system. Often there could be some type of suction. It is a closed system, some type of suction device placed there as well. But typically you want the reservoir below the level of the chest so that the chest fluid we're talking about edema, edematous or serosanguinous fluid, can flow freely out of the chest down into the reservoir system. Now, in this case, we've talked about as the patient is sitting up, the chest tube becomes dislodged. Which of the following actions is most appropriate for the clinician to perform first? Well, the first thing you need to do is to place a gloved hand over the insertion site. Now, you don't want to apply pressure here. Rather, your tactile pressure, enough pressure to hold your gloved hand over the insertion site. The reason you do so is you want to prevent air from entering the pleural cavity or from the chest cavity. And so by placing a gloved hand over there, you are occluding that insertion site so air cannot enter the glove cavity. You'll then want to notify nursing staff as quickly as you can. A lot of times you'll if you're in an intensive care unit, you can often see the nurse. You could call to the nurse, or you could push the call light. There's a bunch of ways to get their attention. And that would be the first thing you do. You would place a gloved hand over the insertion site, then notify the nursing staff, and then they would come in and expeditiously either reinsert the tube or call the physician. The physician would come and reinsert the tube. Now, these other answer options, activating the emergency medical response system, that would be the case after you have placed some type of occlusive dressing or gloved hand over the incision or the insertion site. Rather, in this case, you'd want to perform that activating the emergency medical response system. You do that after you had already placed the gloved hand over the insertion site. And chances are, again, is this a life or death scenario? It is not at the moment. It could turn into that. However, at that precise moment, you would just want expeditious care. So rather than emergency care, you're in expeditious care. That's a distinction I draw in my mind between whether it's a 911 call, which is truly life or death, or expeditious referral, which is clearly important and requires intervention, but could be done not on the 911 call, I suppose. Other answer options including applying pressure to the insertion site and additional lengths of tubing. Now, adding pressure to the insertion site, although that would occlude it, you could also either damage the chest wall after some type of surgical intervention has been, really that's the reason why it's there in the first place, or you could just limit their inspiratory capacity because you're applying pressure directly to the chest wall. In either case, you're not going to apply pressure per se. Rather, you'll be placing a gloved hand, some type of occlusive or occlusion over the insertion site. And then adding additional lengths of tubing would not be particularly relevant. You would do so only if the length of tubing was insufficient for the activity you were performing. But if it had become dislodged, then you're going to want to replace that, have the nursing staff replace that as quickly as possible rather than do any type of additional tubing lengths. And then the other option, return the patient to supine. Rather, you'd want the patient to remain in a sitting position. Again, this puts the lungs at the best advantage possible. It keeps all the fluid down low. It doesn't permit the chest from filling with air as quickly as it would if you were supine. So being in a seated position would be ideal. So returning to supine would be ill-advised. So of these answer options, when you have dislodged the chest tube, here's the order of events. You want to stop the activity, place a gloved hand over the insertion site, notify the nursing staff, and try to help the patient stay in sitting if possible. And granted, there would be some cases where that's simply impossible. However, if you, again, in this case, we're talking about the intensive care unit where nursing staff is immediately available, you're going to want to get them involved as quickly as you could. So all told, a chest tube, of the key considerations, you'll want to not dislodge it. It doesn't necessarily preclude activity. You may need to add additional lengths of tubing and you would be doing this with nursing staff. When I say you would, as the PT, as a part of the interdisciplinary team, would work with nursing staff to be able to do some type of activity that could require additional lengths of tubing. You'll want to keep the reservoir at floor level or bedside level, certainly below chest level because it is gravity fed. And then in the case that it becomes dislodged, you'll cease the activity, place a gloved hand over the insertion site, and get nursing involved as quickly as possible. All right, so there you go. There is the question about chest tubes and chest tube protocols. Again, part of your system interactions on test day. Be sure to check out all the other content we have over on ptfinalexam.com, plus all these other great episodes that we have on the podcast. And if you haven't yet, it only takes a moment. Go ahead and head over to either Google Play, Apple iTunes, Spotify, wherever it is you're listening to this, and leave us a 5-star review. It takes just a moment. It helps so much as we're trying to get the word out about this podcast. So with that, we'll bring it to a conclusion. I hope you have a fabulous day. Keep a grin on your chin. Will Crane fist pumps all around, and I'll catch you all in the next episode. Thanks.